Hello everyone and welcome to this webinar. This is the first webinar that's being hosted by Health Systems Global's Translating Evidence into Action thematic working group. My name is Heather Cogswell and I work for USAID's Health Finance and Governance Project, and I'm also a member of the Translating Evidence into Action TWG. Today, I will be starting us off with a brief background of who we are as a group and why we're coming together today for this webinar. Then I'll touch on some brief webinar logistics, and we'll get into the meat of our discussion, introducing our speakers and starting the panel discussion. Then we'll have some time for questions and answers, and then we'll wrap up. As you may know, Health Systems Global is a community of health systems researchers who champion health systems research and dialogue among both researchers, implementers, and policymakers. The Translating Evidence into Action TWG is one of the newest working groups commissioned by Health Systems Global. As a group, we recognize that the need for strong evidence to support health system strengthening efforts has gained increasing attention in the past few years. However, there continues to be a gap between the creation of new and solid evidence from health systems research and the translation of that same evidence into policy action. As a group, we believe that these challenges aren't inevitable, and we propose that with the right level of support and interaction between researchers and decision makers, that the translation of research findings into actionable policy is an achievable goal. Therefore, the specific focus of this working group is the translation of health systems evidence into policy action. And really, our group is a place to share best practices, lessons learned, practical guidance, and other tools, with the overall aim of decreasing the current gap between what we know as researchers and what we do as policymakers. As a group, we set out to do 4 key things. The first is to enable researchers to support the use of health systems research. The second is to raise awareness among policymakers and other key stakeholders about the need to value, demand, and use evidence. The third is to create opportunities to dialogue and share best practices in evidence translation. And finally, we aim to be a group that collaborates with other Health Systems Global thematic working groups to promote evidence translation. Today, we'll be hearing about an example of evidence translation that took place in Chile. And we're coming together today because we really thought that this country example is a great illustration of the link between evidence translation theory and practice. As some of you may know, our TWG has agreed to adopt the framework, which was previously developed by Dr. John Lavis and others, that covers both supply-side and demand-side strategies for translating evidence into policy action. When we talk about supply-side strategies, we're talking about the production and the display of evidence and producing that in a form that's more easily accessible to policymakers. When we refer to demand side, we're talking about making sure that policymakers and end users actually ask for data and commission needed research on a timely basis so that it can be part of their routine decision-making process. Throughout today's webinar, we will refer to this supply and demand side framework. We realize that it's easy to talk about these frameworks and theories in the abstract, but our goal today is to really show how 3 of these supply and demand side strategies are reflected in the design of Chile's evidence-informed health benefits plan. Today, we have invited 3 authors of a new paper that the Health Finance and Governance Project recently published. And the paper looks at the use of evidence to design health benefits plans based on research from 25 countries. For today's discussion, we don't have the time or the scope to look at 25 countries, so we're going to narrow it down and focus specifically on the example from Chile. Before we move on to get into the discussion, just a couple of housekeeping rules for the webinar. As we go along, if you have questions, we would love to hear them. Please type them into the question pod, which is located on the right of your screen. We will receive those questions that you submit and we'll address them during the Q&A portion after the presentation. In addition, we ask that when you submit a question, make sure that your name is included along with the question. With that background out of the way, I think we're ready to begin. I'm here with 3 colleagues, and I'll hand it off to our host, Gina Holtz, for introductions.
Okay, thank you, Heather. Hello, everybody. My name is Gina Holtz, and I will be hosting the presentation and the question and answer portion of this webinar. It's a pleasure for us to be here today. We really appreciate the opportunity to discuss the research that we've done on the use of evidence to inform the design of health benefit plans with the technical working group. So thanks a lot for having us. As Heather mentioned, our research was done on behalf of USAID's Health Finance and Governance Project, or HFG as we call it. HFG is a 5-year global project that is led by our company, Apt Associates, along with 7 other implementing partners on behalf of USAID. The HFG project supports low and middle income countries to pursue universal health coverage, to expand access to primary and priority health services, and to achieve better health outcomes. It's my pleasure now to introduce 2 of our colleagues, Sharon Nakimowski and Lauren Peterson. Sharon, thanks for joining the webinar.
Thanks, Gina.
Okay, and Lauren, glad to have you here.
Thank you, Gina.
I'd like to let our listeners know that Sharon and Lauren are the 2 principal authors of the review on the use of evidence by 25 countries to design health benefit plans. I'd also like to recognize the contributions to this research by one of our implementing partners, Results for Development, and through them, key informants from the Joint Learning Network, which is a community of practice of health systems practitioners and policymakers. Okay, so let's get started. Sharon, let's begin with you. Please tell us more about why you and Lauren chose to focus on the experience of Chile.
Thanks, Gina. As you and Heather have mentioned, we reviewed 25 countries in our study on the role of evidence in the design and update of health benefit plans. Chile's was one that was, the example from Chile was very well documented thanks to experts such as Lilian Escobar, Veronica Vargas, Ursula Gideon, and Ricardo Bitron, among others. We are indebted to their work in our understanding of this example. This case also illustrates some of the strategies for evidence-informed action presented in the framework used for this technical working group. The 3 here listed on the slide, both on the supply and the demand side. On the supply side, strategies so that users conducting research can do so with an understanding of the priorities and information needs of the end user. And then on the demand side, strategies to change the environment for policymaking in ways that encourage evidence-based work, and before that, having users ask and indeed pay for the evidence they want. So we hope, as Heather pointed out, that this discussion today can kind of make real how these strategies look in policymaking.
Okay, thanks, Sharon. So a key element of the research concerns the use of evidence. Lauren, for this research, how did you go about defining what evidence is?
Well, to be honest, we actually really struggled with finding the proper definition for evidence, especially because we wanted to look beyond the more narrow definition that we were seeing in the literature. As a result, instead of coming up with an explicit definition, we really tried to focus on ways to organize and understand how evidence was used. Interestingly, Chile actually really helped us in this process. Chile has a very well-documented case of extensive and diverse evidence use in their health benefit package plan, and this really played a large part in developing this definition. Ultimately, we ended up creating several categories of evidence based on what we saw used in different health benefit plans in the literature and through interviews. As you can see, we ended up coming up with 5 categories. In the first category to our left, we have clinical data, which might include burden of disease data. Next, we have unit cost and actuarial data. In the third group, we have health system level analyses. These might include health system constraints, both on the supply and the demand side, cost effectiveness analysis, and health technology assessments. In the fourth category, with social preference data, this might be gathered through focus group discussions or population level surveys. And finally, with implementation data. For countries that might have a newer health benefit package, they might be looking at results from pilot studies. Countries with more mature benefit plans might be looking at monitoring and evaluation data.
So Lauren, I hear you describing a range of categories under which different types of evidence were identified. These range from quantitative statistics to things like public opinion. Was there anything that you didn't consider to be evidence?
That's a really interesting question, actually. We ended up considering quite a few things that we did not consider to be evidence. I can give you two examples. One is historical precedent, and the second is the preferences of key stakeholders who might be motivated by political, economic, or even personal factors.
Thank you, Lauren. Okay, Sharon, let's go back to you. Could you please outline some of the basic characteristics of a health benefit plan and tell us about Chile's health benefit plan in particular and how it was designed?
Sure. Well, to start with a health benefit plan, in our definition, health benefit plan is a policy instrument for explicit priority setting, something that allows governments to be more deliberate and more transparent about their resource allocation decisions. It defines the population who has access to the benefits of the policy, as you can see in the first column on the slide, and their benefits, so the services provided to them and who provides them, and the level of financial support provided to beneficiaries when accessing those services. AUHE is the Chilean health benefit plan. It was established in 2005. AUHE translates to universal access to explicit guarantees. The second column shows some of its key characteristics. So with what population will benefit? It's a fairly universal for the full population, and in that it was designed, in fact, to address some inequities in the system between the public and the private subsystems. And so it, covering the entire population, addressed those inequities. What services will be covered? It's an essential package of about 80 priority services covering 60% of the disease burden. In terms of financial protection, the premiums and copays are linked to the ability to pay, with exemptions for the poor. Importantly, AUHE, as with all health benefit plans, have the benefits linked to explicit financing flows. AUHE financing comes not only from premiums and copays, but also from other sources, such as revenue from an increase in the value-added tax, which is earmarked to this purpose. The right side columns of this slide show some examples of the criteria used for making decisions and the evidence base associated with those criteria. So it illustrates then the linkages between evidence and policy design decisions in this case. So yeah, AUHE is Chile's health benefit plan intended to guarantee essential services to the entire population, and it's a policy that was used to address equity issues and improve transparency.
Thank you, Sharon. So Sharon, you've mentioned 3 of the strategies from the LAVIS framework that are reflected in the Chilean case. Perhaps we can go through each one of these now in greater detail to understand them better. So the first strategy that was mentioned was about the supply side, and I'll just read it. It's conducting research in partnership with anticipated users to ensure it addresses priorities and meets information needs. Lauren, Could I ask you to describe in what ways the Chilean example shows that it was considering the needs of users?
So I think first it's interesting to consider who are the users of evidence. In Chile, we see a lot of different stakeholders. These might include policymakers, health service providers, industry, and even the public. Today, since we are really focusing on translating evidence into action, I think it's interesting to look at an example involving policymakers. The development of AUGE was part of a broader health reform in Chile. The president at the time, President Lagos, and Dr. Hernan Sandoval, the leader of the Interministerial Health Reform Commission, really tried to look at other countries to see what they could learn and really try to develop strong processes from the outset. One of the countries that they looked at for successes and challenges was the United States. They noted in the failed health reform in the United States during the 1990s, at the design stage, only technicians were involved in reviewing the literature, with less involvement from politicians. In response, President Lagos and Dr. Sandoval created processes that really tried to protect the technocratic nature of the legislation, as the successful passage of AUGE as an evidence-based health benefit package also really depended on skilled political leadership. From the outset, they really tried to consider the priorities of policymakers and the evidence and processes that were required to ensure political engagement while also minimizing technical disagreements. So what can we really learn from the Chile case? In a lot of the countries that we reviewed as part of our research, we found that it was often a lot of, one challenge of political pressure was to really try to inflate the plan's contents. Politicians tried to promise more than what could be included in the health benefit plan. In Chile, we found that the consistent use of evidence by policymakers and the gradual broadening of AUGE's scope reduced fiscal pressure during the health benefit plan implementation. What is really particularly notable about this example is that the leaders of the reform drafting this legal process were both champions of evidence use and also experts in understanding the political process.
Thanks, Lauren. So let's turn now to the two demand-side strategies that were noted. The first of these is sending strong signals at all levels that research evidence is a key input into decisions. How is this strategy reflected in the Chilean example?
Sure. So I think in the Chilean example, when we're talking about strong signals, we mean legal processes. As the initial AUGE health benefit plan was written into law, the Chilean government also institutionalized a legal process for updating it. Interestingly, gathering and applying evidence is really central to the update process. So we have a slide here that walks us through the update process in Chile. As the diagram indicates, the legal process first requires that the Ministry of Health commission studies needed to inform the process. Specifically, this might include listing out potential services that could be added with their effectiveness in extending or improving life and cost effectiveness. As mandated by the Ministry of Finance, prioritization must also have an associated cost per benefit fiduciary estimated. Once the Ministry of Health and Ministry of Finance agree on a proposal, they send it to the AUGE Advisory Council. This council includes 9 experts in their fields, which may include health economics, medicine, epidemiology, etc. 6 are university professors, and 3 are presidential employees. None have any contractual relationships with the Ministry of Health or the Ministry of Finance. They're supposed to be a really independent commission. They often deliberate in private, but have been known to debate, sometimes publicly, about the inclusion or exclusion of health conditions in the health benefit plan, particularly in cases where you might be lacking consensus on priority status or supply-side restrictions on services in the country. Once the Advisory Council agrees on recommendations and makes revisions, the Ministry of Health and Ministry of Finance issue a joint decree that establishes the new set of services as guaranteed to beneficiaries by law. This is really one of the few countries that we saw in our review that really had these legal institutionalized processes. Health benefit plans are often adjusted sporadically, sometimes by external consultants, with rules that might change with each new round of adjustments that might be influenced by political or economic factors. Chile is really an exception. They've created and applied an algorithm that combines different criteria. We found in one paper by Vargas and Poblete that they found that this was really applied fairly consistently. Use of evidence was really used throughout the update process. And this was really made possible by the institutionalization of the process.
Thank you, Lauren. Thanks for walking us through this process used by Chile to conduct evidence-based updates. Let's turn now to the third strategy that was mentioned. That strategy is commissioning needed research or research syntheses on a timely basis. Sharon, I'd like to ask you if you could please comment on how the Chilean approach to designing its health benefit plan might illustrate this point.
Thank you. This strategy actually can also be seen in the law that we just discussed, the law that is establishing evidence-based updates. As you can see, the first point shows that it is legally required for the Ministry of Health to commission evidence as part of the update process. This was also true in the original design of AUHE. Leaders, whom Lauren has mentioned, were themselves champions for the use of evidence, and they empowered institutions responsible for design with the means to commission needed research. And this research was indeed carried out and used. For example, these reformers were very intent to have AUHE reflect public demand. So the Health Reform Commission was given the budget and authority to conduct focus groups, the results of which informed a household survey on preferences for services to include in AUHE. As this slide shows, this information then played an important role in the multi-criteria priority setting process for selecting benefits to cover as explicit guarantees. So the key point here is that assigning responsibility and funding to specific institutions for generating needed evidence can be really helpful in ensuring an evidence-based process. At first, this may require champions of evidence use, that is, individuals seated in positions of power who are committed to ensuring evidence informs the process. But ultimately, this is not a long-term solution. Taking the role of champion and giving it to the law can protect the technocratic nature of reform even after the end of the tenure of those champions.
Okay, thank you, Lauren and Sharon, for this overview of the Chilean example and how a country has used evidence to inform policy, in this case, to design a health benefit package. Before we respond to some of the questions that will come in from listeners, I'd like to pose a couple of additional questions to the two of you right now. First, the Chilean case, of course, sounds like a success story in evidence-based policy making. But what might have been some of the challenges that Chile faced, and what might not have worked so well?
Thanks. Yeah, it was certainly a success in that they passed an evidence-based policy and even an evidence-based process to reform it into law. But reformers in Chile didn't have everything they needed when they started. Critically, they didn't have good projected budget and costing information, which is, of course, critical evidence for ensuring financial sustainability. They also faced political challenges, both from within the government and external to the government. Interestingly, it was in part because reformers in charge used that, the household preference data in a way to align the policy with demand, that they were able to garner public support. And that public support was then instrumental in overcoming the opposition. So yes, there were challenges, insufficient data, political, but reformers still did manage to pull through and pass an evidence-based policy and used evidence in a way as a tool to fight the political opposition.
Thanks, Sharon. We're talking about this a single country case, that of Chile, but I'm wondering how this process might play out and how it works in lower income countries where evidence might be more limited and resources are more constrained. What are your thoughts about that?
It is certainly a concern. You know, Center for Global Development 2012 report notes the budget for generating health technology assessments is $90 million a year. Certainly, low-income countries can't afford that and may have less to work with. And this is a challenge because we believe, even if we can't prove, that evidence will make policies like health benefit plans more likely to achieve intended goals. But there's also another concern, and that is of inaction. No country can ever have all the evidence they need. In a paper, 2013 paper, Marco Livrani articulates that concern that policymakers may prioritize issues where evidence is fully available and push to the side issues, however urgent, where interventions may have greater evidence requirements. Acting without evidence to guide you and not acting at all to address important issues, both are causes for concern.
Right. So this issue, this is a big issue of kind of inaction. What can low and middle income countries do to avoid this pitfall?
So I think we found a number of different ways that countries are trying to keep moving forward, particularly when they feel like they have a narrow window of opportunity to pass a reform with political support. One example, for example, in the Philippines, might be turning to global guidance, adapting global estimates when possible. Two other examples are really interesting. The first is in India. In India, they have a health insurance scheme known as RSBY that targets below poverty line households. They did not have sufficient evidence to develop an explicit health benefit plan. As a result, they decided to provide each household with a maximum benefit. For example, if a household member were to be hospitalized, the household would be reimbursed up to a certain threshold, regardless of what services were used for the hospitalization. The second example is in Ethiopia, where they use community-based health insurance to target low and informal sector populations. In this example, they decided to move forward with a health benefit plan. However, they first piloted it in a number of communities to really try to identify successes and also identify challenges. They really tried to work on these challenges and improve the health benefit plan before extending it to the entire country.
Okay, thanks, Lauren. So it sounds like there are, across these very different contexts, we're hearing about very different responses to try to move forward with under conditions where evidence is quite limited. It's really interesting. I think we're getting some questions now from our listeners, so perhaps we can begin to take some of them. They look like great questions. Shall we take the first question? What I'll do is read the question and then we'll respond to it. So the submitter is Daniela Rodriguez. Daniela's question is, can you explain your thinking behind not including precedent, but especially policymaker preferences and motivations in the groups of evidence? These types of factors tend to have an important influence on decisions made. I think the question is about precedent. Yeah? Sharon? Yeah.
Thank you for this question. When we defined evidence, this was not to, our intent was not to say evidence is the only factor influence policy. In fact, we weren't sure that evidence the role of evidence would be anything at all because of that concern. Not concern, but the reality that political factors really are so important. We did want to draw some boundary around what is evidence and what isn't, not to say that, again, not to say evidence is the only factor, but as a way to look at the interaction between evidence and those other factors. How might those other factors hinder or facilitate in some situations, for example in Chile, the use of evidence or not?
Thanks, Sharon. Moving on then to another question. Let's take one from, just a moment, we're pulling these up now. This is a question from Nidhi Kirana, who is a health systems researcher at Johns Hopkins. The question from Nidhi is, what did it take for evidence champions to get political buy-in to incorporate the use of evidence into law? What were the major impediments that they faced?
So I think part of what made some of the champions really successful was the political capital they had. In the example of Chile, it was really the president of the country who really took this on as an important issue, something that he really supported and that he really understood the importance of using evidence, but also really had the political power to carry it through. I think this is similar in India, where leadership from the top really drove being able to try to develop the best evidence-informed policy that would be possible. In the case of India, they really didn't have evidence, so they tried to build the firmest foundation they could in the event that evidence could be gathered later. In the more mature country example of Chile, he really made sure that they had the resources, the international experts, the capacity within country to really develop an evidence-informed policy. In fact, when there were disagreements between some of the policymakers and the technocrats, he got personally involved and really helped to navigate some of those disagreements. So I think really having that political power was really key.
Yeah, I mean, just an additional comment on that. I think we may not see a lot of sort of documented experiences of champions, but that we have heard many anecdotes. And as we talk to people who have been involved in these reforms, oftentimes you hear about a champion who at some stage of the reform process really plays a critical role to overcoming the obstacles that are particularly important at that moment. Thank you, Lauren. Next question. This is coming from Agnes Munya. The question is, how were trade-offs made between social preferences and cost effectiveness of the interventions and the resources to pay for the essential package?
Thank you for the question. In Chile, actually cost effectiveness was explicitly listed as a lower level criteria than social preference. The two most important criteria that they considered was disease burden, so health status, and social preference. And they did consider cost effectiveness, but again, it was kind of as a second level criteria. So, the actual how those criteria that they bring, that multi-criteria process exactly went down, we don't know. But we actually also were particularly interested in, the trade-off between high-cost interventions, covering high-cost interventions, or versus covering cost-effective services, because again, there you might not have a lot of crossover. Again, we're actually not quite sure exactly how that tension played out in the process, but we do know that some percentage of both cost-effective and high-cost services were ultimately covered. So they were able, to somehow balance the two competing desires.
Okay, thanks. I think key word there is balance. It's really a balancing act. I think we were able to see that across a number of country examples. Thank you. Let's move on to another question. This is one that has been submitted by Lynn Makarayan. What should you do if evidence conflicts with political interests? Do you have any recommendations? That is a great question. Lauren, do you want to?
Sure. So I think that's a very relevant question and something that I think we see in every single country in our report. I think that there are two things that we've really learned from Chile. I think the gradual update process has been really important so that they can gradually build support and also review the evidence. But I think most importantly, the institutionalization of the process. I think that this, and writing it into law, I think has allowed the process to continue and to be applied systematically. I think it also allows it to really survive changes in political leadership as well, that the process is in place and is not dependent on one political party that might really support health reform and then be changed by a second political party that might come in with a different idea about what health benefits should look like. I think it's really interesting too to look in Chile because they had a lot of opposition from the medical associations there. They were a very politically powerful organization, but the government was really able to get the buy-in from the public to really counter that opposition from the medical associations. To contrast, in Colombia, where the medical associations are also very powerful, the medical associations were able to get to sway the opinion of the public to the point that they're looking at changing how their health benefit plan is designed. So I think really thinking about processes and institutionalization and really just trying to communicate with the different stakeholders. I think that Chile makes a really important effort to do that and really to try to engage stakeholders, particularly the public, to try to have their support. And when they have their support, they gain more power and be able to use the evidence.
Did you see any examples where evidence was available but disregarded by policymakers?
Well, I think we did. We saw some examples where in Colombia, for example, they took a lot of effort during their initial health benefit plan design to really try to gather a lot of evidence. In fact, in one of the resources we used from the IDB, they really said that Colombia had a dream team of experts really supporting their efforts to design their health benefit plan. In the end, they ended up losing a champion of evidence use who's tragically passed away, and ended up having political pressures almost overriding the use of evidence, so that it ended up having a lot of political factors determining the design of the health benefit plan. In addition, in Ghana, with their national health insurance scheme, which has a health benefit package but uses a negative list. And when I say negative list, I mean that they only define the services that are not covered in their health benefit package. They also reviewed evidence, but felt a lot of political pressure to expedite the process, and ultimately political factors kind of overrode some of the use of evidence there, so that they ended up with frankly an unsustainable health benefit package simply because they decided just to exclude a number of factors and promise so many different benefits.
Okay, thank you. We can take another question now. Just a moment. Let's just to pull these up. They're just coming up on the screen, so please bear with us for a moment.
Oh, okay.
Okay, this next question here is another Danielle Rodriguez. How long does the process normally take to update a health benefit plan?
So thanks. We don't know exactly. We know it's been done about 4 or 5 times in Chile, and that it's fairly, there isn't another requirement to go through legislature again. And in fact, the council's recommendations to the Ministry of Health and the Ministry of Finance's proposal are binding. So it's a fairly streamlined process. We'll have to look into how long it takes.
Okay, thank you. Next question. This is a question from Nasreen Jassani. The literature on E2P has evolved from supply and demand side to consider more integrated approaches and network relations. The response on political power also speaks to this. Can you provide examples of where other approaches that were not supply or demand facilitated E2P in Chile? Evidence to policy.
Thank you for the question. Yeah, we very much agree that when looking at a policy, when looking at what actually happens, some of this differentiation between supply and demand kind of doesn't feel as clear. That the one strategy necessarily involves both sides. So you know, we definitely recognize that from the framework that we use, the three strategies in the framework. These were the ones that seemed to be reflected best in the case of Chile. But we definitely recognize that limitation, or you know, as long as it's recognized, perhaps to expand on the fact that these aren't just demand and supply, but are integrated strategies actually.
Thanks, Sharon. Another question from Agnes Muria. What was the most important lever that contributed to the Chile success? And are there any country examples where political will was not the primary catalyst for change and design in the benefit package?
So I believe as my colleague Sharon may have said earlier in the presentation, there were really two key factors that contributed to Chile's success: the integration of political and technical actors and the institutionalization of the processes. I think in the Chile example, we really can't stress enough how important really thinking about the processes from the outset, not just what the initial health benefit plan would look like, but really what the update process would be too, were really critical. I think thinking about really how actors are using evidence, how to collect it, how political factors can really influence the use of evidence. I think there was a lot of thought that really went into the design in Chile. Thinking back to that update process slide, you don't just have the government actors and the Ministry of Health developing the evidence and reviewing it themselves, but they have this independent commission too, really trying to give an objective look before going back into the political system. I think you just cannot stress enough those two factors of integration and institutionalization. And I think, and to be honest, and Sharon, please feel free to jump in here, but I think in most of the examples that I'm thinking of right now, really political will was the primary catalyst for change in design of the health benefit plan. Often it might be part of a larger health reform, but political will was definitely strong. I agree.
Yep, very powerful. Thanks, Lauren. Let's take a question from Yashin Singh from the University of Cape Town. The question is, were there opportunities for citizens in Chile to participate in priority setting, evidence evaluation, and policy making?
Thank you. We're not aware of any such opportunities in Chile. There is a really interesting case of that, though, from South Korea, where the government has recently begun, they have a citizens committee where they do that. They provide a short list of services and some criteria to consider to this citizen committee, and that citizen committee then comes up with recommendations that policymakers then consider in the final update process. So that's definitely a case to look at with interest, and might also, like the case of Chile, have some good lessons for other countries.
Thanks, Sharon. Let's see if we can take one additional question. Just pulling up the questions here. Maybe let's take one from Connie Ho, who is a health policy researcher at Hopkins. She had an additional question about policy champions. Did the successful policy champions across the different countries possess any similar characteristics, such as political connections, personalities, etc.?
I think, well, I mean, to be honest, a lot of what we know about champions is really from anecdotal evidence and key informant interviews. But I would say that, yes, a lot of them do have political connections and very gregarious personalities, very good at bringing people together, very good at not only trying to get both technocrats and politicians at the table, but really being able to translate the languages so that the two parties can understand each other. In a lot of cases, I would say that the champions are maybe more political actors, but they understand the importance of technocrats, and they really try to find ways for the two groups to communicate with each other. So I think they're really, while they do have the political connections, I think what really makes them unique is their ability to bring the two sides together.
Yes, and I would just contribute an anecdote from my side, having worked with people in the ministry in India with the RSBY program there. The person who was the champion of that particular program when it was starting possessed all of those characteristics, was a successful career government bureaucrat, but highly personable, strong personality, also did not take no for an answer, was sort of, I think it's a really important personality trait, because there will be opposition. There will be people who say, you can't get that done. You won't get that through Parliament. There will be somebody who will block you from doing that. But it was certainly a personally kind of clear experience for me to see how this person really single-handedly, with a lot of help, but the force of that individual's personality, I believe, had a great, played a significant role in getting that program off the ground. Okay, so I think we're going to take up to 2 more questions here because our time is running out. The next question is from Bhavish Jain from India. What is the most important question, and how do you sustain the demand for evidence, especially during change in leadership, either politically or administratively? What are the vehicles to ensure sustainability in the use of evidence?
Well, as we've tried to show here, one vehicle is law. I guess easier in a law-driven society. But the fact is that I think importantly the champions for evidence were focused on that idea to institutionalize their commitment to evidence and not just focusing on the use of evidence in the original design. Certainly when there are no champions around, but you do have those procedures already in place, that can also facilitate use of evidence in the future. Otherwise, also these kind of environmental changes, changing the climate for evidence use, can also have long-term kind of effects and can maybe give rise to new champions in the future. So those kinds of investments where you're changing the way people are talking and thinking about it within the government, it's also, or within policy processes, can also support that use in the future beyond, again, the tenure of any one or two individuals.
Thanks, Sharon. So I think we have time for one last question, and I want to thank everybody who has submitted questions and apologize that we're not able to get through all of them in the time that we have. But we'll end with a question that comes from Olivia Bierman. Olivia's question is, how can Chile's success story be repeated in other countries? What are the top 3 ingredients?
This is definitely a challenging question. In some ways, I think there are things that are very difficult to replicate. Chile worked on this for many years. While we're not considering historical precedents as a type of evidence, Chile is really building on a stronger health system with a lot of years of experience. There are also things that we see in Chile that are really important, like champions, that we actually do see in other countries, but it's really hard to replicate the personality and the political capital of a champion. But I would say if you can't replicate the champions, the individuals themselves, I think that the foresight that President Lagos and Dr. Sandoval had to really try to think about the processes from the outset, to really try to think about how they really recognize the importance of evidence, and they really recognize the fact that sometimes the political factors, the economic factors can really override the use of evidence. So I think they really made a strong, concerted effort to make sure that evidence was part of the process and was really central to the process. So I would say just the foresight to think that out. And I think as we see in India too, recognizing maybe they didn't have the evidence up front, but thinking about, well, what can we do in the long term? What can we do today? And just really thinking in the long term. I think the second things that they carried out that we've kind of discussed over and over again is trying to bring the different stakeholders together at different points to take into consideration the public opinion, to really try to communicate with those stakeholders, including maybe even medical associations with people that will be carrying out the benefits and who will be influenced by evidence through their clinical guidelines. And I think finally, institutionalization. I don't think in the legalization, I don't think that we can stress enough how important that we feel this was in the case of Chile. It's really allowed them to apply use of evidence systematically and pretty thoroughly, and also to do it over a number of years. They've now done 3 updates, and this seems like the process is working, and they have this systematic, legalized process that will survive multiple political changes.
Yeah, and even anticipating the need to establish that process early on, it's so easy given it's really hard to get a health benefit plan passed. I mean, it's a big, complex policy that has wide implications. Focusing on getting it passed is hard enough, but to have, and countries that do that, you know, now are thinking, oh, gosh, we need to have some policy to update it. And it's then hard to get that together after the fact. But including that update process, even within the original law, I think was a really key part of the success.
Okay, thank you so much, Sharon and Lauren. Let me turn it back over to Heather for our wrap-up.
Great, thank you, Gina. And I just want to thank all of you for joining and participating in today's active discussion. The questions that you've sent in have been great. Just to wrap up, we've heard today about one example where evidence was used to design a health benefits package in Chile. And as I mentioned at the outset, we chose this example because it's a great illustration of the link between evidence translation theory and practice. And as you've seen, Sharon and Lauren have been able to relate 2 of the demand side and 1 of the supply side strategies that are represented in our TWG's framework to the Chile process. Just a few key takeaways that I've been thinking about throughout this discussion that I wanted to share. The first is that we've heard that evidence translation is a process and it's very complex. But despite this, the Chile case has shown us that it's also something that's doable, which is encouraging for all of us. The second point that we've heard is defining what evidence is can actually be a challenge. And in fact, the example from Chile, or the case from Chile, has helped us to think more broadly about the definition of evidence going forward. And then finally, ultimately, Chile's decision of what services to cover in their benefits package is a political decision. They had to think through a whole bunch of aspects of the plan that they needed evidence for. We've heard population data, social preference data, burden of disease, et cetera. The technocrats used this evidence to help identify the resources required to cover services, and it was critical to have this evidence basis as they went forward with making potentially politically touchy decisions about the benefit package design. As we come to the close of today's webinar, I wanted to wrap up with a few additional